come in, have a seat. There you go. So, good morning. We thought one of the things we wanted to do this morning was have a conversation, especially with a global perspective and what we should be learning, with two gentlemen that were part of the global track yesterday, and I think represent different stories that we're following as part of Manova in terms of, as we think about the future of health, where we're going to get inspiration, where there are best practices and learnings coming today, and what we can learn. So, Dr. Naresh Kanumilli, a true story is we have been watching, he's a distinguished cardiologist, works in diabetes, works in Greater Manchester on community health, so great advocate there. But he's very involved with an experiment that's going on right now in the UK with their national health system that we're going to talk through that I think is pretty powerful, and we can bring some lessons back even to this community. Assi Gol is here also from London, but is an Israeli citizen as well, is representing a new blood startup that's very, in my mind, representative of the high level of innovation technology we're seeing out of Israel. And he does a number of other interesting things that we're going to explore. So, welcome, gentlemen.
Thank you very much.
Good, good. So can we start with you, Naresh?
Yep. So,
you want to tell us kind of what's happening in Manchester with the national health system and what you're doing completely different, and then I'll follow up with some questions I know.
So first of all, thank you for inviting me over, and it's been an honor and humbling experience being here. Didn't expect the invite, but I'm so grateful to be able to come and talk about Manchester. Now, when we talk about Manchester, I think I get told off by the chief exec there because we're not talking about Manchester, we're talking about Greater Manchester, which actually includes 10 regions, and we have a population of about 2.7 million. And we have the same problems that I've been listening to over the past couple of days here. But the important thing is what the central government decided was that they would say to us, here's the money. We want you to almost become a republic. You manage the health and social care system. So they gave us $6 billion annually and said, we are leaving you in charge of the health and social care system. So that gives us an opportunity to look at what's happening locally rather than wait for the national health or the central government to tell us, well, we needed to do this, we need to do that. So it gives us an opportunity also to look at what the local needs are, put in place plans, and try to work on those, which is what we're trying to do.
That's a pretty overwhelming opportunity. I can imagine, as we think about our healthcare system, you know, you've heard a lot of complaints over the last few days, things that could be much better.
Yeah.
But when somebody finally turns to you and says, okay, here's £6 billion, you can do whatever you want. How do you organize yourself to start to think through that problem? And were people, did they want that opportunity?
I think...
Go ahead.
It's £6 billion as opposed to 6 million. I thought you said 6.
Oh, no, I said billion.
Okay, £6 billion we needed. So I think the general public around Manchester and Greater Manchester were desperate to have something unique. And it's almost an experiment where the government is hoping for us to be successful because they want to pilot this in other areas as well. So the conversations in Greater Manchester have all been around what is it, like the determinants of health, what we were listening to you about the social determinants. How do we make changes beyond just medical care? So what do we do about cities? We're listening to Gil Pelanosa talk about things and Dan Bjortner talk about things. All those things are part of the system that we're trying to change in Manchester. So it's been a bit of a... But they've given us 5 years to do this. They didn't say, here's $6 billion, we want some outcomes in the next year. They said, here's 5 years, do what you need to do, and we'll review the situation in 5 years' time. So we put in place a lot of new things to try and help us. But having listened to the people here, I find that actually Minneapolis and Manchester are very similar. We have the same problems. I can be sitting here initially and came in and thinking, well, actually, we are much better than you guys because care is free.
Yeah.
All right? But then having looked at it, listened to you guys, I'm thinking, well, actually, we're not dissimilar. The same problems exist. access, poor outcomes, despite easy access, despite not having to pay for care. So there's a lot to learn from you guys as well.
Well, that's good. So what are the big changes that we're going to see in 5 years in Greater Manchester versus what would have just normally happened through NIH?
So the big things we're hoping are the life expectancy, which is lower in Manchester compared to the rest of the UK. Another big thing, healthy life expectancy, that is the age before people start getting diseases.
Right.
We hope to improve that. We hope to change things around variation, zip code lottery or postcode lottery, because if you stayed in my area, you're more likely to live about 10 years longer than somebody who lives in the center of Manchester. The biggest thing that we've done is we've made it easy for innovation. So previously, if anybody's tackled with the NHS, Assi will tell you about this, you go through bureaucracy that like there is no tomorrow. So it kills innovation, stifles people's imagination. But what we've done now is set up a thing called the Health Innovation Manchester, where we bring together academia, commissioners, industry together, and just say, okay, what is important for Manchester? Can we get something, say, from Minneapolis and say, well, this project is there, that's working really well there, can we bring it to Manchester? If they think, yes, it works, they will do the project management, so easily they will just try and scale it. So you don't have to go running around to different departments.
So you've got a platform for quick and open innovation. They can come forward with the idea and say it's worked elsewhere, and you can fund it, right?
Yeah,
and
so
you can project manage.
Yeah, so what they'll do is they'll look at it and say, is this relevant for Manchester? Will it work for Manchester? And if they say yes, and they do a small pilot of sorts, and then they'll say, okay, we will project manage this, give you access to who you need to get this scaled up. And the even better thing is, if it works in Manchester, you have an opportunity to move it around the country. Mm-hmm. So their remit is to share best practice around the country. So that's why I think it's exciting to be in Greater Manchester at the moment.
Do you have people from the other systems watching pretty closely what you're doing?
Yeah, it's like a hawk. So they're waiting. I think there are some areas well, let's say they're not desperate for us to fail, but I think they'll think, okay, let's see what Greater Manchester can do. And then if we are successful, they're going to start applying to become another devolved state.
That's great. So you talked about, as you rethink how you're going to channel and funnel these resources, both human and the initiatives, as well as the funding. So moving more to preventative, moving more to community.
Yeah.
Equalizing the zip codes or postal codes. If I looked at your budget, is that where I'd see the big changes?
Yeah, so it's all moving down to neighborhoods and localities. So we're trying to develop workings in neighborhood and patches, because each patch is different to other things. So I can't say, well, what works in South Manchester will work in Bury or Stockport. So we want to look at patches, what is important in that patch, and then see if we can put support in place, get the people and community leaders involved to try and see what we can make better in that area. Because the last thing we want is you get really good diabetes care in one area, and then you go to another area and you get completely different care. We want it to be consistent across both patches. That's what we're trying to get to in the end.
But still through that neighborhood contact.
Yeah.
So that, are there, for many people probably in the room, tell us a little bit, if we go look at Greater Manchester, how diverse is it? I know you said income disparity, but are there cultural disparities?
Huge, yeah. So there are areas of affluence which are mainly white Caucasians, and then in the central Manchester is a lot of ethnic minorities, and Asians, Pakistanis, Bangladeshis, but we're getting a lot of other immigrant population from Poland, etc. So we have a really diverse and culturally rich, but also that gives us other problems about language barriers. How do we inspire them to follow good, healthy advice and things like that? So we need to tailor everything towards the diverse communities. And that's a big challenge. But we're getting to use the local community leaders to help us with that, rather than just saying, here's English, get somebody else to translate it for you.
So maybe a best practice here, something we can take away is, you have a best practice in some aspect of medicine, diabetes management, et cetera, but you're taking it local and then having to be of the neighborhood through the leadership of that neighborhood.
So, for example, we set up, since I got involved with the Greater Manchester Partnership, we set up what's called the Tackling Diabetes Together. And it's an initiative that we decided that actually we want to work it from the bottom up. It's always been a top-down approach.
Yeah.
So we decided we will talk to so we changed language. We don't call them patients anymore. We'd like to ask them, what would you like to be called? So we call them persons with diabetes because, again, we talked about mental health, social determinants. It's a vital aspect of management. So we talk to them about holistic care. So we call them persons with diabetes. At least it gives us an identity with the person, so I have to relate better to them. And we also try to use a strapline whereby we empower the patients to say, well, no medication without education. So it's almost getting the person with diabetes the power to ask the clinician, actually, why are you giving me the tablet? What is it going to do to me? That'll enable them to improve adherence and compliance. But at the same time, we could use all the tools that I heard here. I'm really keen to take some of this stuff back from here and say, wow, let's use some of this in Manchester.
So a real transparency to their care.
Yeah.
And I love this changing the poetry of the language that you know, how you refer to the people will change how accessible they will be in pursuing that. So a little transition here. So how does someone from a huge, are you bringing in innovations from just the UK, or are you bringing them from other places?
We are, so I'm been tasked with also saying to people around here, come to Greater Manchester, bring us your innovation. We really like to trial things that might help us because we want the project to succeed. And we really want to look at different ways of engaging with the population, diverse population. So is there something we can do that can get everybody engaged in the process? So yes, we made it easier now. It's not completely easy, but it's much, much easier now.
Yep.
There's one point of contact. You bring what you think might work to Manchester. I'm happy to help with trying to decide whether it will work or not. You bring it, and we will look at it and say, actually, if this works, we will help you scale it.
Good. So that is a call out to some of the entrepreneurs in the room right here in Minnesota, that if you think you have something, you should definitely try to network today before you take off pretty soon to the airport. But I think there's a powerful lesson there, because whether you have a private system or a public system, they can all be pretty bureaucratic. We've heard that the last few days.
Yeah.
They can be slow to get innovation. They can feel very top down. So yours is an experiment I know we're gonna wanna watch. I'm going to transition to you for a second. You're also in London, but you're from Israel. Great background, by the way, McKinsey background. You do a number of innovative things using big data and artificial intelligence. But tell us about the company, the startup you're representing right now, and why you're here.
Yeah, of course. So thank you for having me. This is the first time in Twin Cities. I'm excited to be here. I've been advising Sight Diagnostics for the last 7-8 years. They are an incredible company. They developed a device that allows you to bring complete blood counts to the point of care. So this is a device using a very different technology than the one used today to do complete blood counts. It uses machine vision and artificial intelligence to be able to count the different cells within a count, allowing us to create a device that is much smaller and can deliver lab-grade complete blood counts in a doctor's office or in a pharmacy setting. That is pretty much it. We're at after 7 or 8 years of R&D, we're in mid-clinical trials in the US with the FDA, hoping to get regulatory approval 2019.
Oh, good. So pretty soon.
Yeah.
One question I wanted to explore, because you're from, I think we're all aware that there's this, as we think about the future of health, there's this ecosystem. There's something about Israel with the incredible amount of innovation that's coming out of a very small community. What does Israel have? What are you guys doing that we should be doing here? What's different?
So I don't know Minnesota well enough. So I'd caveat it by that. I'll probably speak a bit about how Israel is different to London, different to Minnesota, and I'll try to say something about that. So I think I think that there's been a lot of books and a lot of smart people speaking about how Israel got to innovation. There's a country that grew up in a very specific way. There are cultural elements. There are government interventions early on that made a difference. And there's the military, which creates incredible talent. There's a lot of drivers. But if you think of a single lesson that I would try to take here, and it's the biggest difference that I see from most other countries, definitely from the UK and probably from the US outside of Silicon Valley, that would be mindset. I think Israelis on average have an incredibly risk-taking, rule-breaking approach to life and to business. And on average, the US is more formal, and in the conversations I've had here, it feels more risk-averse, feels more timid.
Timid. It's like we want to make sure that this is going to work, and do we not dream big enough, or do you think we're more evolutionary than revolutionary?
So I think when you think of scale, I think the US is unbelievable. Once an idea works, scaling it, making it efficient, making it grow, there's no one who can do it better than in the US. And these are mass generalizations about the continent, right?
Yes.
I think that it's not about being dreaming big. It's about believing that you can actually drive that difference. It's an overconfidence that characterizes successful entrepreneurs, I think.
Okay.
If you look at London and the difference between Israel and London, then I think this is, again, it's the biggest factor that plays in favor of Israel. But London has a different uniqueness, because not every innovation hub can be driven by the same success factors. I think London's biggest success factors are a real focus on what they do best, which is fintech. And you can see an incredible amount of successful startups coming from a city that is focused on finance, a significant focus on finance. And the second is diversity. It is probably the most cosmopolitan city in the world today. And using and harnessing that diversity of backgrounds and the diversity of thinking is incredibly powerful. So if I compare London to Minnesota, I think there's one incredible strength that you guys should harness, and that's a focus on healthcare. It is a very healthy, smart thing to focus in an innovation hub on a topic. I think the thing that you should be focusing on improving is increasing the diversity of the population.
No doubt.
It's already a trend. I've heard from a lot of people here, but it feels very different. It still feels very, it does not feel like walking in the streets of London.
Yeah, oh, absolutely not. And I would say one reason we're here at Manova is we fervently believe that we should be a health innovation center for the world, but also really for the United States for sure. There are a lot of people competing with us, so we wanted to have that platform and have that annual platform where we talk about this. Is there a startup that you are aware of, and one or two in Israel, that you're most excited about, or that you admire, or you see? Is there anything you could share with us?
You mean a startup in Israel, or
or maybe broadly, globally, a startup that you're seeing that you're most excited about?
So maybe a startup that is not a startup anymore from Israel that I was following very closely and was very happy to see they were sold to Intel, allowing it to scale, is Mobileye. I think it's the largest exit Israel had from a startup being sold. It was sold to Intel a year ago for more than 15 billion. And a few reasons I'm very, very excited about, or was always very excited about them, is one is the focus on practical AI. So they use computer vision to solve the challenges of autonomous driving. And there's a big difference between when I look at healthcare and AI, there are far fewer examples of actual practical uses that go all the way from data collection to being deployed to patients. I love the examples that actually have been able to go all the way. I think the second reason is that they really went big. Most startups in Israel end up being sold very early, and when they're very small, Israel spawns a ton of innovation, doesn't generate many large corporates. The same mindset that is very helpful for innovation is less helpful for creating companies at scale. So I think that is a great example of a company that got to real scale.
So many of our big companies should definitely be going to Israel and picking off the best ideas and bringing them here to scale them.
They already do. Like if you look at the path, the standard path of an Israeli startup is to be sold to an American corporate. Now, more and more to Chinese corporate as well. But
yes, so maybe we should do some kind of Manova exchange where we're seeing some of these things and bringing them here where our innovators can scale them pretty quickly and the like. You talked about practical use of artificial intelligence, and we have seen a lot of artificial intelligence here. Talk a little more about how you make artificial intelligence practical.
I think healthcare has a unique challenge in the way that data is set and collected. I think a lot of people before me mentioned that. Unlike in a consumer space where you can just sell someone a watch that both collects, or a phone that collects the data, then analyzes the data, and then acts and recommends at the back end of it. That's a very simple ecosystem. The ecosystem of healthcare data is broken, siloed, painful. If you look at the evolution of medical records to become electronic, I think that has happened. Harnessing the data in those have not happened yet. In one of my other hats and other roles, I led the GDPR program for a large e-commerce where I work in the UK. That's a general data protection regulation from the EU. And the thing that dawned on me as I went through it is that data truly belongs to people rather than to no one else. And I think that if you look at the Googles of the world, the Facebooks of the world, which are companies I deeply admire, but they provide free services by owning your data. I think that approach probably would not work in the same way in healthcare. And I think the healthcare is an industry that should harness the patient/consumer/person as the true owner and the hub of his full data set, whether it's the medical data or the social data or another. And the innovation should happen through platforms that allow the connections of all those data sets, but have to happen through an individual rather than through large corporates that take advantage of the data.
And certainly, go ahead.
Just agreeing with what Assi is saying. In Manchester, again, we've got a project going, and we're using a system called My Diabetes, My Way. So it gives the person with diabetes access to their information so they can use it whichever place they go. So whichever healthcare, social care, whatever, so they can actually access the data. And you were also talking about artificial intelligence and the other newer technologies. So again, looking at it from the person with diabetes point of view, one of the things we found was people going to diabetes clinics don't know what's going to happen to them when they go and see the nurse or the healthcare practitioner. So we're working with a company in London who develop virtual reality clinics. Yes. So they almost wear the virtual reality, and they know that when they go in, they're going to get the foot check, blood pressure check, and the importance of those things. Because there was a study done by Novo Nordisk called Dawn 2 study, which showed that there's a complete disconnect between what happens to you as a patient and what I think I did to you as a clinician. So they come out and ask them the same question, and the person said, well, they didn't examine my leg. Well, I actually asked the clinician, they said, well, I did do the leg test because they didn't discuss it. And with regards to AI, I was just, again, sat on some place where they're using AI for detecting pulmonary nodules. So because the number of x-rays that go on, and the number of, we're struggling with the radiologists to read these things. So they're using AI technology to just go through all the x-rays and then identify ones that need a second opinion from a radiologist. So it's kind of reduced the time to diagnosis of cancer from, I don't know, 2 weeks or whatever to bang within a few hours. So it's happening in some situation. But I agree with you. The information needs to be owned by the person whose information it is, which is where the problem is.
If I go back to Sight, one of the principles we take is that as you do your blood test, regardless of the setting this would happen, whether it's a doctor's office or a pharmacy or whatever, you can transfer the data to your practitioner. That is great. But you can then do with the data whatever you choose. There's an incredibly detailed image of your blood, which offers your blood count, but potentially far more than that. And you can share that data with research institutes if you choose, or you can share it with another company that would offer, I don't know, personalized diets based on your blood tests, etc. But you as the hub of your own data is part of the principles that lead us.
Very, very interesting. We have a couple more minutes. I just wanted to, I'm curious, given that you've traveled so far to come to Manova this year, can you each talk, is there one or two things that you heard or you thought about differently than, or you're thinking about differently now than when you walked in here 2 days ago?
Okay.
It's a very long list. It'd probably take me a while to digest it all. I think I was incredibly impressed by indigo agriculture. David Perry presented, I think, yesterday. And I think three things about it are really, really interesting. One is the scale and magnitude of the challenge that is being undertaken, which is transforming how we consume fruits and vegetables, and it's just huge. The second is how they are thinking of, if currently the industries are siloed, how they're thinking of trying to solve it end to end. I think there's a lot of parallels that you can bring into healthcare. We've also heard from the primary care, One Medical, thinking about the end-to-end process to be able to truly transform it. So that thinking is really impressive. Tackling a systemic problem through systemic means. That is a
and
big
that
takeaway
certainly has been one of the things, I think, as we thought about Manova and as we thought about the programs is, one of the major themes is not working in a tight vertical. Sometimes you find true innovation there, but really trying to think over the life of a patient, over the life of a person. What are all the things that you can impact there? What about you, Doctor?
As a clinician, as a GP, I would say I'm an entrepreneur in the strictest sense of the word, like Assi is. But I think for me, there are a few things I've learned. One is, as a clinician, I've learned some new words, disruptive and leverage. Things I don't think, okay, fine, this I'm going to add to my vocabulary. The other thing I also learned was I'm glad Kirk Cousins is Minnesota Vikings because I met him 2 years ago, so I'm glad I'm here. And a few other things, the things that really changed a lot of my opinion here, the talks that I heard in the beginning with Dan Burton and Gil Palanosa, because it's something that's close to what we're doing in Greater Manchester about how to change the social system and the cycling paths and all those things. And the other big thing I learned is what Walmart and UPS, I mean, we don't think of them as healthcare. Now suddenly they're in healthcare. UPS, that was a very powerful discussion we had yesterday about the logistics and how they're delivering packages to diagnose cancer. Fantastic. So we were thinking, well, actually, this is phenomenal that we could use all this to help us in delivering better care for our persons.
Yeah, Chris Cassidy from UPS, I mean, their whole strategy about using logistics to improve the lives of every person on the planet, organs, everything that they're looking at is pretty revolutionary.
And Walmart, the stuff they're doing, access to healthcare, which is the biggest thing for any situation. So in a way, I was thinking, well, actually, we are very similar across the, we're separated by the ocean, but we're very similar in the needs and the wants of the persons, citizens and the patients. So I think there's a lot to learn, and I think I picked up quite a few things which I want to take back and discuss with the higher-ups there, and probably get some of you guys to come across and help us with our system, and we could come across and help you with what we're doing.
Well, Manchester is a major hub of innovation right today in a lot of fields.
Yeah.
My old field of food and design and advertising. And so it would be good to have a great partnership both with Manchester as well as a stronger partnership, I think, with Israel. So
yeah.
that'd be great. Well, thank you for your time.
Thank you.
Appreciate you doing this. We're going to now take I believe it's a short break to 10:15, and we'll resume our programming then. I do want to point out, we are, as of this morning, 7 flu shots short of 100. Please help our Walmart pharmacy guys. They so badly want to break 100. I'm sure there's somebody out there that doesn't have their flu shot. Take advantage of this. We will have VR. We talked about VR, but the Mayo VR is really terrific in the back. For some of you, if you've been inspired to be a different kind of leader, where Don Owen started us this morning, we've got the University of St. Thomas, which is leading a number of healthcare MBAs. There are people back there to talk with you. And then for everyone, we're building an ecosystem of innovation, of world leadership here. Make sure you're part of that conversation and you join Medical Alley, okay? And they're in the back too. They would love to talk to you. That's what this is all about. Gentlemen, thank you for coming all the way to Minnesota. It's good for you. And you got to come back next year, okay?
We'll be
Better
back.
weather.
Okay, let's hear it for these guys.
Thank you.
We'll see you at 10:15.